Hello, everybody. I'd like to welcome you all to Pediatric Grand Rounds. I'm going to start with our land acknowledgement. We'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I'd like to now invite our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our speaker for today.
Thank you, Dr. Hirsch. It is my great pleasure to introduce our speaker for today, Dr. Shailaja Srinivasan, who is a clinician scientist and assistant professor of pediatrics in the Division of Pediatric Endocrinology here at UCSF. I actually didn't realize this until I read her bio. We have a common training background. I did not go to the Pondicherry Institute of Medical Science in India to do my medical degree. I did that in the Netherlands. But I trained at the Tufts program in Boston, and you went to both that program and to SUNY Downstate. You did your fellowship in pediatric endocrinology at the Massachusetts General Hospital and Harvard Medical School, and joined UCSF after her training in 2016. Here, her work focuses very much on type 2 diabetes in youth. She has a funded NIH-funded research program using pharmacological and genetic approaches to evaluate pathophysiology and therapeutic strategies for youth with type 2 diabetes using large data sets and clinical trials. She oversees the pediatric type 2 diabetes program at the UCSF Medicine Clinic for Pediatric Diabetes, and she is also one of the associate program directors of the fellowship training here. And her passion for working in the area of type 2 diabetes is rooted in her experiences growing up and training in South India, as well as her recognition of the disproportionate burden the disease places on youth of color. And with that, I'm going to invite Dr. Srinivasan to the stage to tell us what she is working on.
Thank you so much for that introduction, and to the organizers for the invitation and opportunity to present. It's really very special to be presenting at our own Pediatric Grand Rounds. So here's my disclosure. And here's an outline of today's talk. So I'll first be talking about the burden of type 2 diabetes in youth, after which I'll spend time discussing what is known about the genetic architecture of type 2 diabetes in youth, and lastly, touch upon pharmacogenomics, some future directions, and more. So unfortunately, type 2 diabetes is no longer a disease of just adults. This is data from the Search for Diabetes in Youth study that shows the change in incidence of type 2 diabetes between the years 2003 to 2018, further divided by racial and ethnic subgroups. You can see that for all youth shown in purple, there was an increase in incidence, but that the increase is particularly dramatic in youth of color. And I want to contrast this with the change in incidence in type 1 diabetes, again from Search for Diabetes in Youth. And you can see that while there's a subtle increase, there has been a subtle increase in the incidence of type 1 diabetes. It's not as dramatic as type 2 diabetes and does not show that disproportionate burden in youth of color. So type 2 diabetes is an emerging epidemic in youth. So when you look at prevalence data, again from Search, the prevalence of type 2 diabetes doubled from 2001 to 2017. The data from Search stops after this, but we know, particularly during the COVID pandemic, that these numbers are actually even worse. And there's a fourfold projected increase by the year 2050. And type 2 diabetes, for type 2 diabetes, there is a disproportionate burden on youth of color and indigenous populations around the world. And it used to be the case that we would say that type 1 diabetes is the diabetes of childhood and type 2 diabetes is the diabetes of adulthood. But that is no longer the case because in certain pediatric subgroups, such as adolescent youth of color, type 2 diabetes is now more common than type 1 diabetes. So type 2 diabetes in youth has an aggressive disease course with an early risk of complications. We know this from the Today study, which was a study that looked at different medication outcomes in youth with type 2 diabetes. And the Today study also did long-term follow-up on these youth. So they had a total of 500 participants in the long-term follow-up study. And at the time of this data, the mean age of the participants was 26.4 years, and the mean diabetes duration was just over 10 years at 13.3 years. So the Today study showed that the incidence, the cumulative incidence of any microvascular disease, so we're talking about retinopathy, nephropathy, neuropathy, was 50% after just 9 years of follow-up and was 80% by 15 years of follow-up. The Today study also looked at time to onset of microvascular complications. And while on average, the first complication occurred about 6 years after diagnosis, the second and third complications, as you can see, followed soon after at 10 and 12 years respectively. And so complications not only are aggressive in type 2 diabetes, but they also occur earlier in youth onset type 2 diabetes compared to not just adults with type 2 diabetes, but also youth with type 1 diabetes. So shown here is data from the Search for Diabetes in Youth study that examined the probability of not having a micro or macrovascular event in both youth with type 1 and type 2 diabetes. So type 1 diabetes shown in blue and type 2 diabetes shown in red. So you can see that this probability decreases, the decline in probability starts much quicker and declines rapidly in type 2 compared to type 1 diabetes. And type 2 diabetes is also associated with increased mortality. So shown here is data from the Emerging Risk Factors Collaboration that examined large data sets, both from the Emerging Risk Factors Collaboration as well as the UK Biobank. And they found this linear trend in both all-cause mortality and cardiovascular disease mortality, according to mean age of diagnosis. So they found that every decade of earlier diagnosis of diabetes was associated with about 3 to 4 years of lower life expectancy. But I thought that the commentary that accompanied this article best summarized the current state of type 2 diabetes in youth. Many years of life lost to young onset type 2 diabetes. So why is it that some youth develop type 2 diabetes? So the answer is as complex as type 2 diabetes. So type 2 diabetes is what we call a complex disease, which is caused by hundreds of common variants and a few rare variants interacting with the environment. So from a genetic standpoint, we have common and rare variant influences as well as epigenetics. And these are just examples, but there are many more. So in terms of environmental exposures, we know that obesity is one of the single largest risk factors for the development of type 2 diabetes. And so the obesogenic diets that youth are exposed to are a contributing factor. Chemicals in the environment, the intrauterine environment, maternal gestational diabetes is a strong risk factor for future development of diabetes in the offspring. And then there are social determinants of health that accelerate the development of diabetes. And this includes access to healthcare, poverty, access to healthy, nutritious foods, access to safe space to exercise, and systemic racism that limits ability to access these resources and care. So my group has been looking at the genetics of type 2 diabetes, which I will highlight in this next section. So there are several lines of evidence for the genetic basis of type 2 diabetes. So twin studies show that concordance for type 2 diabetes is greater for monozygotic versus dizygotic twins. The incidence is much higher in youth of color, so in certain racial ethnic groups. Family history is an independent risk factor for the development of type 2 diabetes. And we know by the existence of rare monogenic forms of diabetes, or MODY, that single base pair changes in coding regions of genes is sufficient to cause diabetes. So heritability estimates for type 2 diabetes, when they've been calculated, range anywhere from 25% to 72%, depending on the population in which they are derived from. So type 2 diabetes, again, is what we call a complex disease caused by environmental factors overlaid on a background of genetic predisposition. And this concept was very elegantly highlighted in this classical study from the 1980s, that it showed the incidence of type 2 diabetes in Pima Indians according to body mass index. And they found that in individuals who had one parent with diabetes, the risk of diabetes increased by 2.3-fold compared to no parental history. And this risk increased by close to 4-fold when there were two parents with diabetes, again, even when accounting for increased BMI. So there is a spectrum of genetic variation contributing to diabetes, starting at this end with common variants. So type 2 diabetes is mostly caused by a contribution of now hundreds to thousands of common variants, which occur more commonly in the population, but each individual variant has a very low effect size on disease risk. On this other end of this spectrum, we have the monogenic diabetes, or MODY, which are classic Mendelian diseases in terms of genetics. So they're caused by single genetic mutations, but that genetic mutation has a high enough effect size to cause disease. And in the middle, we have low frequency and rare variants, of which we know a little bit less compared to these both extremes. So in terms of in the world of adult diabetes genetics, there's been an explosion of genetic discovery over the last 2 decades. So there are now hundreds and even close to 1,000 genetic loci that have been found to be significantly associated with type 2 diabetes. And shown here are all the variants and all the and the size of the circle represents the sample size in which these studies were conducted, which are now close to 1 million samples. And then the colors represent the ancestral groups. And while purple represents populations of European ancestry. And so up until very recently, unfortunately, almost all studies were done in populations of European ancestry, but more recently, you're starting to see more color indicating representation from other ancestral subgroups. So when so much is known about the genetics of type 2 diabetes in adults, why study the genetics of type 2 diabetes in youth separately? Because there are unique differences between youth and adult onset type 2 diabetes. So to name a few, type 2 diabetes in youth has a female predominance, which is unique to the disease occurring in childhood. And then puberty is a very unique concept that occurs, that is often the tipping point for a child developing diabetes. So we all know that puberty is when there is an increase in many hormones, including growth hormone and sex hormones, that cause a transient increase in insulin resistance in all youth, regardless of whether they go on to develop diabetes. But this is often the tipping point for a child who is at risk to then go on and develop diabetes. And then there are pathophysiological differences. So we know from studies like TODAY and RISE that youth have greater insulin resistance for any degree of adiposity compared to adults, and that youth also have a greater insulin secretion for any degree of insulin resistance compared to adults. So this greater insulin secretion is thought to be what causes a greater, faster decline in beta cell function in youth compared to adults. Youth, as we know, are unfortunately subject to increasingly obesogenic environmental exposures. And then youth with type 2 diabetes have a high socioeconomic burden. So disadvantaged racial and ethnic groups are at high risk of type 2 diabetes at all ages, but this association is particularly strong in youth. So in 2014, when I was a fellow at Mass General, I had the opportunity through my mentor to be involved in the establishment of a consortium for pediatric type 2 diabetes. And this was formed because at the time, there was nothing known about the genetics of type 2 diabetes in youth. And it was thought that a collaboration was needed to systematically increase sample sizes and to be able to study this. So this was a collaboration of 3 different study groups: the TODAY study. So the original clinical trial had 699 participants, and the ancillary genetic study had over 2,000 participants, and Phil Zeitler was the PI of TODAY. Search for Diabetes in Youth, which is a population-based study, an observational cohort that had 449 youth with type 2 diabetes. And T2, and Donna Davila was the PI of the study. And then T2D Genes, which is an adult type 2 diabetes genetics consortium with access to tens of thousands of both cases and controls, adults with type 2 diabetes and without diabetes. And shown here is a Jose Flores, who was the PI and who was also my research mentor in Boston. So putting it all together, in Prodigy, we had over 3,600 pediatric type 2 diabetes cases.
Third floor, IDN, code P. Third floor, IDN, code P. Third floor, IDN, code P. Third floor, IDN.
So putting it all together, we had over 3,600 pediatric type 2 diabetes cases, all of which have genome-wide genotyping and whole exome sequence data. And to our knowledge, this is the largest collection of pediatric type 2 diabetes genetics cases. So in Prodigy, we investigated the spectrum of genetic variation that's contributing to type 2 diabetes, starting with common variant analysis. So we performed a genome-wide association study, or GWAS, for type 2 diabetes in youth. So looking at what we had in terms of our population, so in terms of cases, pediatric type 2 diabetes cases, we had 3,006 cases, and we chose the controls to be greater than the age of 50 and free of diabetes. So we had 6,000 adult controls, and we also had access to 856 youth controls with genetic data. The mean age of the youth participants was 15 years compared to 54 years for the adult controls and 14 years for the youth controls. There was a female predominance in the youth cases, not surprisingly, compared to the adult controls and the youth controls. And the majority of the youth cases were youth of color, as you can see here, and the adult controls were chosen to match this. Not surprisingly, again, all of the youth cases had obesity, and the adult controls were lean, as well as youth controls were lean, and all of the youth cases had glycemic metrics that were in the type 2 diabetes range. So when we talk about a genome-wide association study, this is a method of surveying the genomes of many people, looking for genomic variants that occur more frequently in those with a specific disease or trait compared to those without the disease or trait. And we do this systematically by performing multiple association tests across the entire genome. So in performing this GWAS, we identified 7 variants that were associated with type 2 diabetes in youth. Shown here is Ling Chen, the analyst who led this work. So this is what we call a Manhattan plot. So the chromosomal coordinates are shown on the x-axis, and the negative log p-value is shown on the y-axis. And the genome-wide significant threshold of 5 times 10 to the power minus 8 is shown here in black. So that very stringent p-value is because we're performing thousands of association tests. So we identified 7 variants, 6 of which were previously identified in adults, including the well-known type 2 diabetes disease, locus TCF7L2, MC4R associated with obesity, CDC123, KCNQ1, IGF2BP2, as well as SLC16A11, which is uniquely contributes to diabetes risk in Mexican Americans. And we also identified a novel variant in the gene PHF2. However, just because we only identified 7 variants doesn't mean that these are the only variants associated with type 2 diabetes in adults. It's likely that we identified much less than what's identified in adults because our sample size was much more modest than what adult studies use. So then we went on to construct polygenic risk scores. So polygenic risk scores are calculated as a weighted count of genetic risk alleles in the genome, with the risk alleles and their weights derived from prior genome-wide association studies. So in this case, we constructed polygenic scores from 303 published adult type 2 diabetes variants at that time. There are now many more that are known in adults. And we calculated the odds ratio for type 2 diabetes in youth cases versus adult controls, adult cases versus adult controls, and youth cases versus youth controls. And across all 3 combinations, we found that the odds ratio was type 2 diabetes was highest in the youth cases versus adult controls, highlighting the aggregate genetic burden is very high in youth compared to adults. So in Prodigy, we then went on to look at the frequency of the contribution of low frequency and rare variants. So these rare variants are typically found in the exons of the gene, and a mutation in the exon is more likely, is thought to be pathogenic because it is in a functional region of the gene. And so when we do rare variant analysis, there's sort of two ways to do this. One, by single variant association testing, but also by gene burden testing, where we're looking at the contribution of multiple variants in an exon. And again, looking at the distribution of those variants in those with disease and those without disease. So in Prodigy, we did rare variant analysis with 3,650 youth cases, 24,000 controls. We did joint variant calling, ancestry matching, and at the end, we were left with 3,005 cases and 9,777 controls, in which we did both single variant association and gene level burden testing. And this was work led by Jason Planick and Sean Kwok at Boston Children's and at the Broad. We found that rare variants also contribute to type 2 diabetes risk in youth. So in terms of single variant association, we found that there were 4 variants that were associated with type 2 diabetes in youth, all previously identified in adults. And when we looked at the gene level associations, there were 3 genes that crossed the significance threshold. MC4R, again, well-known obesity locus HNF1 alpha, and then a novel variant in ATXN2 alpha. But putting it all together, when we looked at the liability variance or the proportion explained by genetics in youth onset type 2 diabetes compared to adult onset type 2 diabetes for both common and rare variants, what we found was that youth with type 2 diabetes are 3 times more likely to harbor common variants for type 2 diabetes compared with adults with type 2 diabetes. And youth are 5 times more likely to harbor rare variants for type 2 diabetes compared with adults with type 2 diabetes. I'm going to pause here because I think that this is a point that's very important to acknowledge, because type 2 diabetes, especially in youth, is a disease that is associated with a lot of stigma, a lot of shame and blame. But it's very important to acknowledge that there is a strong genetic contribution to this disease, which is even higher in youth compared to adults, and that the odds are stacked against most of these children who are then exposed to these obesogenic exposures before they go on to develop diabetes. So in Prodigy, we also investigated we also looked at monogenic diabetes or MODY. And what we found was that a small but substantial fraction of youth who have clinical type 2 diabetes, in fact, have MODY. So we examined the whole exome sequence data in 3,333 participants in Prodigy, and we found that close to 3% of these participants actually did not have type 2 diabetes, but had a likely pathogenic or pathogenic variant in some of the most common MODY genes. So HNF4 alpha, GCK, HNF1 alpha, PDX1, INS, and CEL. And when we looked at the clinical differences between those who had a MODY variant and those who didn't, the MODY youth had a younger age of diagnosis, lower fasting C-peptide levels, were less likely to have hypertension and had greater HDL cholesterol. But most importantly, I think the take home is that those with MODY had no clinical features that could clearly distinguish them between those that didn't have MODY. And this is, again, work that was led by collaborators Jennifer Todd and Tony Pullen. And then more recently, we wanted to examine how the MODY calculator performed when we used it in youth with a clinical diagnosis of type 2 diabetes. So the MODY calculator has been developed by the Exeter Diabetes Group, and it's an online calculator that's now very popular, in which you can input variables, and it'll give you a probability of MODY. And based on that probability, there's a threshold of, if the probability is greater than, say, 25%, it is recommended that MODY genetic testing for MODY be pursued. So some of these variables include age of diagnosis and sex, time to insulin treatment, BMI, A1C, parent affected with diabetes. This is work being led by Ray Kryenkamp, who is a research fellow, who is a fellow at Boston Children's. So what we found when we looked at the MODY calculator and applied it to 3,279 participants in Prodigy, out of which 3% or 100 had a likely pathogenic or pathogenic variant in a MODY gene. We found that the MODY calculator was not at all helpful for differentiating MODY and type 2 diabetes, because according to the calculator, in those who actually had MODY, there was the MODY probability was 98%, but the probability of having MODY was actually 92% in those in which we knew from genetics did not have a genetic variant for MODY. And then when we looked at the ROC curves, we found that the MODY calculator variables perform no better than BMI alone, again stressing the point that MODY and type 2 diabetes often can present similarly, and that MODY, a diagnosis of MODY, should be considered in those with a clinical diagnosis of type 2 diabetes. And so moving on to the next section of the talk, pharmacogenomics and some thoughts about future directions and more. There is marked variation in response to type 2 diabetes medications. So this is data from the ADOPT study that shows the change in hemoglobin A1C across some of the most commonly prescribed type 2 diabetes medications in adults, metformin, sulfonylureas, and TZDs or thiazolidinediones. And you can see that there is a great degree of variation between those who respond and don't respond, and how and to what extent they respond. And this is typical across all diabetes medications. And focusing on metformin alone, because metformin is the foundation of type 2 diabetes in youth. Metformin is first-line therapy for type 2 diabetes in youth, and it is recommended that even when we add additional agents, youth continue on metformin. Because it is oral, it is low cost and globally available. We can get metformin for less than $5 for if you were to pay out of pocket for 30-day supply, and then it's covered by all insurances. I mean, it has an extensive safety profile. So it is a medication which has a longest safety profile in type 2 diabetes, greater than 60 years of data in adults, but greater than 20 years of data in children, even in children. However, we know that youth do not respond as well to metformin compared to adults. For example, in the TODAY study that looked at three different medication options: metformin alone, metformin plus rosiglitazone, and metformin plus lifestyle. Across all the groups, 52% of participants, all of which are on metformin, did not have sustained glycemic response to metformin, compared to just 21% of adults in ADOPT. So the reasons for non-response is something that our research group is examining, looking at various angles, and these could be clinical, genomic, or pharmacological factors. But I want to focus on the genomic factors for the purpose of this talk. So there is a genetic basis to response to metformin. So heritability for change in metformin, for hemoglobin A1C change in metformin, has been estimated to be anywhere between 20 to 34%, which shows that a considerable proportion of treatment response to metformin is genetically determined. And indeed, there have been 5 published genome-wide association studies in adults that have identified genetic variants related to metformin response in adults. ATM SLC2A2, which was work done here at UCSF by Kathy Giacomini's group, and then also PRP F31, CPA6, STAT3, and the variants listed below. But when it comes to metformin pharmacogenetics, it's not just about having a list of variants. These variants actually cause clinically relevant differences in treatment response. So as an example, SLC2A2, again, this is the variant that was identified here at UCSF, encodes GLUT2, which is one of the main glucose transporters in the liver. And it was found in the MetGen consortium, which had over 13,000 adults on metformin, that C allele, so those who had CC homozygotes at RS8192675 at SLC2A2 had a 0.33% greater hemoglobin A1C reduction than those who were the T allele homozygotes, with an intermediate response in those who were the TC, who had the TC genotype. So this actually corresponds, the authors then discussed that this corresponds to the effect observed when taking 550 milligrams of extra metformin per day, or half of the effect when an additional drug like a DPP4 inhibitor is added. And this C allele is homozygous in actually 49% of African Americans compared to only 9% in European Americans. So this finding is even more clinically relevant in African Americans. So in Prodigy, we had metformin response data in 506 participants in the Today study. So we conducted a genome-wide association study for metformin response in these youth. Again, shown here is the Manhattan plot, and you can see the red line shows the genome-wide significant threshold. Likely limited by our very modest sample size, we did not identify any genome-wide significant variants associated with metformin response. What we did find that several of the subgenome-wide variants had associations with diabetes related traits. So what we then did was we examined our top findings in 7,812 adults on metformin from the Metformin Genetics Consortium, and we were able to replicate this finding in RS761952229 in ATR and L1 was associated with worse risk metformin response in adults in the Metformin Genetics Consortium, which was the same direction that we found in the Today study. So looking at other applications, potential applications of genetics, let's talk about polygenic scores for prediction of type 2 diabetes. So very obviously, germline genetic variation, especially for a disease like type 2 diabetes that presents in closer to puberty and later, always predates the onset of disease. But however, currently for type 2 diabetes, the predictive power of polygenic risk scores remains comparable to simple clinical risk factors alone, which means that we do pretty well in the clinic in being able to diagnose type 2 diabetes, and we don't need genetics to help us make that diagnosis. However, genetics can be useful to compare individuals at extremes of genetic risk. So a GWAS of 53,000 adult type 2 diabetes cases and 193 controls from Page and Diagram found that individuals who are in the top 10% of the polygenic risk score had an increased risk of type 2 diabetes compared to those with the average genetic risk. And that this risk was different according to different ancestral groups. So it was highest between the two extremes in Asians, followed by Europeans, Hispanic, Native Hawaiian, and lastly by African ancestry populations. So it is possible that polygenic risk scores can help identify individuals at high risk before clinical risk factors like obesity become apparent. And this can particularly, even compare more than in adults, this might have greater utility in children. And then lastly, genetics can help us disentangle the heterogeneity of type 2 diabetes. We are increasingly recognizing that type 2 diabetes is very heterogeneous with multiple pathways related to insulin deficiency and insulin resistance, ultimately leading to that final endpoint of hyperglycemia that is type 2 diabetes. So this is work done by my collaborator, Miriam Adler at the Broad, where she took hundreds of genetic variants that are associated with type 2 diabetes and performed a hierarchical or soft clustering against multiple metabolic traits, and then found that they clustered in 5 different groups. And these groups are what we call endophenotypes or partition polygenic risk scores, relate to different aspects of type 2 diabetes physiology. So she identified 2 groups, islet dysfunction, insulin production, and islet development associated with insulin deficiency, and 3 groups, obesity, adipose distribution, and liver lipid dysfunction associated with insulin resistance. And subsequently, more recent work done by her group has actually identified 12 subgroups, including replicating the original 5 subgroups. So then we wanted to see whether these partition polygenic risk scores or cluster polygenic risk score can be applied to youth because they were developed in adults. So we applied these partition polygenic scores to youth in Prodigy from the Today study, and we found that they did replicate. And as an example, those with the beta cell, high beta cell partition polygenic risk score had a low C-peptide level compared to the other subgroups. And currently, we're examining differences in partition polygenic risk scores in relation to treatment response and disease progression in diabetes. But the ultimate goal of pharmacogenomics is for it to be used in clinical decision making, and that is the dream of precision medicine for type 2 diabetes. Right now, currently, it is very hard to justify using genetics in type 2 diabetes clinical decision making because most of the variants that have been identified for type 2 diabetes have a very small effect size, and the cost of genotyping cannot justify that. However, we're all very well aware that the cost of genotyping is rapidly decreasing. And hopefully there'll be a day when genetics is integrated in the medical record. And I don't think that is too much of a moonshot because even in certain areas at UCSF, such as for pharmacogenomics, genetics is being used for clinical decision making. Because imagine a future where we see a patient like this that comes to our clinic, say a 14-year-old girl with type 2 diabetes who's already on two drugs, metformin and a GLP-1 receptor agonist, which all of our patients now are on. And at a follow-up visit, when she comes to see me, the hemoglobin A1C is 7.5%. So the goal for type 2 diabetes is to keep the hemoglobin A1C less than 6.5% to reduce the risk of complications. So at this point, I do know that an additional diabetes agent is indicated, but the question is, what is that agent? And currently, there's not a lot of guidance to tell me which agent to choose. But imagine a day when we had a clinical decision making support algorithm where we're able to incorporate a lot of these different, where we're able to incorporate features that are specific to that individual. So not only their age and sex and BMI and maybe their lipid levels, but also their genotype. And based on this, we're able to get the probability, likelihood of response, or the likelihood of adverse events for what are some potential next options. So in this particular case, if I got the likelihood of response to empagliflozin was 80% and the likelihood of adverse effects is 10%, I'm more likely to choose this compared to the other drugs in which it seems like the likelihood of response is much lower. But again, this is something that we hope to do in the future, but genetics is not there yet. Because a lot of work remains to be done, there needs to be functional characterization of the identified variants. We are increasingly aware that the environment plays a huge role in the development of type 2 diabetes. And so the study of gene environment interactions, epigenetics is very important. We need to have increased sample sizes through collaboration. So as you've noticed, the sample sizes for most of our pediatric type 2 diabetes studies remain very small. So future type 2 diabetes studies have to prioritize collecting samples for genetics so that we can increase our sample sizes. And there needs to be increased diversity of samples. As an example, in all of the prodigy analysis, I didn't show you any data about the genetics of Asian youth because those numbers were too small for genetic analysis. But for example, in our very own, at our very own hospital, we see a high number of Asian youth with type 2 diabetes. And so there needs to be more representation of all ancestral groups in genetic analysis. So to summarize, type 2 diabetes has a strong genetic basis with a spectrum of genetic variation that's contributing to disease risk. Youth with type 2 diabetes have a greater aggregate genetic burden for both common and rare genetic variants compared to adults. And this could partially explain why youth develop diabetes much earlier compared to adults. A small but significant percentage of youth with a clinical diagnosis of type 2 diabetes may have monogenic diabetes, so it's very important to always have that clinical suspicion. Genetics contributes to variation in medication response, and the future of genetics in type 2 diabetes is very promising with risk prediction, subclassification, pharmacogenomics, and more. And then increased sample sizes and collaboration are needed to advance the field of pediatric type 2 diabetes. With that, I'd like to thank all of my mentors and collaborators from the Prodigy collaboration, especially my fellowship mentor who continues to be an advisor, Jose Flores at MGH, Phil Zeitler and Dana Dabalia, who are the PIs of the Today and Search groups, respectively, the rest of the members of the Prodigy Consortium, my UCSF mentor, Kathy Giacomini, and collaborator, Sukwa Yi, my fabulous pediatric type 2 diabetes research team, Laura, Vani, Emilio, Zach, Kevin, Sujata, and Megan, the entire pediatric endocrine division, as well as additional collaborators at MGH and Broad, including Miriam Adler and Rick Camp. And I'm really grateful to my funding sources. Lastly, I'd like to share that we in the pediatric diabetes clinic here at UCSF are organizing a type 2 diabetes community event. So we've noted that there are very few events for youth with type 2 diabetes. So we're putting on a type 2 diabetes community event, which is an educational health fair with games and fun and carnival style with the goal to build community and leave with a sort of a positive sort of positive feelings about managing your diabetes. This is the second year that we're doing this. Here are some participants shared with permission from last year and some of our own staff members who are dressed as vegetables. And we're doing this in October at Met West High School in Oakland. And this is the fabulous T-shirt that one of our team members designed because type 2 diabetes is most definitely not the type to give up. With that, thank you very much. Happy to take any questions.
Questions?
Brian?
Shai, thank you. That was really outstanding. Luckily, type 2 diabetes is a relatively new thing. Yeah, that's right. And our genome sequence is a relatively old concept that we've had the sequence for many more. So basically, evolution would work on the time scale that can be positive. So I'm wondering if the polymorphisms and mutations that you've identified have elicited some hypotheses about how these are mutations in genes that interact with the environment, or some other explanation about how this happened.
Yeah, no, that's a great question because
Maybe summarize the question for the Zoom.
sure.
Long question, but yes.
Yeah, so I think hopefully I'm summarizing this correctly, Brian, is that the these genetic polymorphisms have sort of existed forever and years, but it's only now recently that we're seeing an increase in incidence or the increasing burden of type 2 diabetes. So what are some possible hypotheses or mechanisms that are contributing to that? And I think that's a great question. And I think it is the environment that has changed the most drastically. So even saying that if the hypothesizing that those genetic influences are most likely the same, I think our environment has changed so rapidly in terms of just the obesogenic exposures in just like processed foods and lack of physical activity that have, I think, contributed to, again, gene environment interactions. And again, against that background of genetic predisposition led to an increase in type 2 diabetes. And that would be sort of my speculation. Yes.
I have a slightly crazy environmental question. Is there any evidence, or has anyone looked for effects of adverse childhood events on type 2?
That is a great question. And I think we're increasingly aware that social determinants of health play a role in accelerating the development of type 2 diabetes. So I think it's important to note that the reason why youth of color have an increased burden of diabetes is, number one, genetics, but it's also because of the disproportionate incidence of some of these social determinants of health, and adverse childhood experiences is definitely one. There is some work associating adverse childhood experiences and type 2 diabetes, more work in adults, but also in children. But we haven't yet integrated that with the genetics to see what some work that we're interested in doing now is. It'll be really interesting to look at the relative contribution of genetics versus some of these social determinants of health. And I think one of the limitations is that these data sets that have genetics don't really examine adverse childhood experiences or have these variables present for analysis. So right now, those are some of the limitations, but I think that is definitely a very important component to type 2 diabetes in children.
And can I just add to that, that I think one of the problematic things that has been highlighted in research literature around race a lot is that I noticed that some of your slides talk about African Americans, which is really a social construct.
versus people from African ancestry, it has a lot more to do with the genetics, right? And that's another really complicating factor in trying to sort this all out.
Right.
That we don't actually use very precise language. Genetically.
Right. Good point. Yes, I agree.
I have an ignorant question. I probably should know this. Is it important, and if so, why is it important to separate out patients with MODY versus type 2? Does it change how you treat them?
Yeah, good question. So some of the forms of MODY have completely different clinical management. So if you have, for example, like a GCK, a glucokinase mutation, or a MODY2, you don't require any treatment because you just have a very slightly elevated hemoglobin A1C. So some of these patients may be on medications that they don't need because they're not associated. And some of the MODY forms are best treated with an oral medication like a sulfonylurea. So again, they don't need to be on insulin, they don't need to be on metformin. And some of these glycemic abnormalities won't go away. So you can't like exercise your way with the GCK MODY. No amount of exercise is going to be going to get your hemoglobin A1C down. So definitely has concrete, clinically actionable consequences.
All right, well, then thank you very much for this great talk. We'll look forward to seeing you in a couple of years and hear more of the evolution of your work. Thank you very much.
Thank you so much, everyone.